Thank you, Jean-Louis. Thank you again all for being with us today. And I would like to thank Nino and Jean-Louis for their marathon moderation, and thank you for being with us. It's very impressive. So the question about...
So you have used 1 minute already.
Yes. EEG, intermittent or continuous. So just to remind you a few concepts, and the EEG has long been used to study the electrical activity of the cerebral cortex. And so the standard approach with EEG shows brain electrical activity as you see here in the form of a line with repetitive wave-like activity. This will be discussed by Paul Vespa, but I think it's just because the question is intermittent versus continuous, to know a bit more about the development in the last decade of a more advanced form of EEG called quantitative EEG, in which the raw EEG signal you see on your left is converted to digital form using the fast Fourier transformation and compressed spectral array, so that using quantitative EEG is also possible to reveal aspects of brain function away from seizures that may be important to the understanding of a variety of neurological disorders. And so this can be used in the ICU, and it's an evolving area of investigation, and so quantify and assess brain function and dysfunction, particularly in neuro-ICU patients. Paul Vespa will talk about it. So the question I try and ask in a very pragmatic way is as to whether we should use intermittent versus continuous EEG. Either you use a standard approach or a quantitative one. And so an intermittent EEG monitoring, usually it's a 30 to 60 minutes recording. And if you go for a continuous approach, it's at least 24 hours and even up to 96, so a few days. Now, of course, both approaches have advantages, and intuitively you can see that if you have a continuous EEG monitoring, you have a lot of recordings to analyze. And in any case, I think that incorporating an EEG is a multidisciplinary team effort and a collaboration between intensivists and neurologists. So the main indications for EEG, the classical indication is the detection and management of seizures. And I will talk also of a few other new indications. Well, unexplained coma is not so new in the general ICU population, but the main area of investigation now is about the role of EEG on top to other brain monitoring tools we discussed yesterday in a so-called brain multimodality monitoring approach, and finally the use of EEG for prognostic assessment. So first of all, convulsive status epilepticus. That's where we use EEG more frequently, and again a classical use of EEG. So should we be intermittent or continuous? Now, if we talk about the most severe forms of convulsive status epilepticus which arrive in the ICU, well, this is more a clinical diagnosis, but there is a proportion of patients having non-convulsive seizures or status epilepticus defined by persistent seizures. So it's quite frequent. And patients with non-convulsive seizures will have impaired mental status, but differentiating between a post-ictal status, the effect of sedatives, medication like benzodiazepine, from ongoing seizure activity can be challenging. So in practical, these seizures, and to distinguish this impaired status of consciousness, you need EEG. And if we talk about refractory status epilepticus, defined by a status epilepticus resistant to initial therapies, so the first and second line, benzodiazepines and anti-epileptic drugs, This is almost exclusively non-convulsive, so that frequently you have initiation of continuous intravenous anti-epileptic therapy, and you have to be aware that the breakthrough and withdrawal seizures are frequent, and these seizures again are non-convulsive, so subtle, clinically silent. You don't see a convulsion, so you don't see any sign, or if there are, they are subtle. And so even if there is still some controversy in refractory status as to whether we should use midazolam, propofol, or barbiturates, and some controversy about the duration, there is no doubt that patients with refractory status epilepticus need a continuous EEG monitoring. And it's also important when you go for an EEG for the titration of therapy, and normally we go for burst suppression therapy for at least 48 hours. And so again, the algorithm is the clinical termination of seizures, but also the EEG termination of seizures. And this is very important, because to terminate clinically doesn't mean that the seizures are over in the EEG. And again, there is this non-convulsive seizures going on. So you need to monitor these patients continuously. And generally, these treatment last at least 24 to 48 hours, and is important to titrate therapy again, and continuous EEG is useful for it. Now, there are other forms, particularly in neuro-ICU patients, and I would recommend this review in Anesthesia and Analgesia appeared in 2009. And there is a variable incidence of clinically subtle or silent seizures, also called non-convulsive seizures or status epilepticus. And this is an EEG from a lady we had with intraparenchymal hemorrhage, who had a reduced in the Glasgow Coma Scale, and we performed EEG, and we found exactly this EEG on this lady. The incidence varies, and probably the incidence is also related to the amount of sedation used in the studies, but can go up to 22% in TBI patients. Has been described as well in patients with intracranial hemorrhages, SAH or intracerebral hemorrhages, with a variable incidence again. And we don't know exactly, there is some debate about the relationship between non-convulsive seizures and outcome. There is an association between non-convulsive seizures and increased secondary brain damage, increased ICP, increased cerebral metabolic distress. But it's not, again, a solved issue as to whether these seizures are a marker of severity, whether we should treat. In general, I mean, we agree that we should treat these seizures, so increase, for example, the sedation when these seizures are present. And I think they are a marker of the severity of injury, and they are part of secondary cerebral damage. Now, we know in these situations that we need continuous EEG, and the reason why we need, even if it's from retrospective studies, is that if you use intermittent EEG, you detect in 11% versus 20% of patients monitored with continuous digital video EEG. So the fact of having a continuous EEG, and if you add the video, is important in the ICU setting, because there may be quite a lot of artifacts in these particular settings. So it's important to differentiate between an artifact and a seizure. And probably the most difficult thing when you interpret EEG and you use continuous EEG monitor is actually differentiating between the seizure and an artifact. So another study showed that detection of the first non-convulsive seizures occurred after more than 24 hours of continuous EEG monitoring in 12%, and even 13% of subjects you required up to 48 hours. So there is an indication of having continuous EEG monitoring in this particular context. And the recent recommendation in stroke, they say continuous EEG monitoring is recommended for any SH patient with neurological deficits that are not otherwise fully explained. And also a word of caution is that you do not want to use anti-epileptic therapy, generalized prophylaxis in these patients. There has been studying showing an association between generalized prophylaxis, anti-epileptic prophylaxis, and actually worse cognitive outcome. So what we do recommend is that if you have these patients and you have clinical suspicion, at least to perform EEG monitoring. In some centers, they perform continuous EEG monitoring for the first 48 hours. Then, of course, it depends on the availability of EEG. But I think that since we know that non-convulsive seizures may at least worsen the secondary damage, they can be frequent. But on the other extent, if you use a one-size-fits-all strategy and you have generalized anti-epileptic therapy, it can even harm the patient. So that there is a rationale for using continuous EEG monitoring in these patients. And this is a study by Jan Klassen showing that the time of continuous EEG monitoring to record the first seizures, as I discussed, half of the patient, even more, it takes 1 to 6 hours, but sometimes you need more time. For unexplained coma, second chapter, in general ICU patients, you see that this is a survey. They use EEG for altered mental status or comatose with recent seizures or without. Subtle eye movements, so can be a non-convulsive seizures, any patient with an acute brain lesion. And what we know is that so-called epileptiform patterns can be triphasic waves or seizures. Here are the risk factors you know. There are some disease-related factors, CNS infection, hepatic or renal failure, also sepsis may be associated with these epileptiform patterns, and solid organ transplant patients with cyclosporine or tacrolimus are at higher risk. And this survey, they seem to agree that the majority thinks that intermittent, so 30 up to 1-2 hours EEG, is probably as adequate as continuous EEG monitoring. So we can rely to this survey and saying that potentially intermittent in this situation is okay. And just briefly, at the end, this will be discussed by Paul Vespa, but I think it's really an emerging field of investigation, is to use continuous EEG monitoring, and mainly with the quantitative approach, to monitor brain function and dysfunction. And there has been quite a lot of studies using EEG to assess delayed cerebral ischemia. And just this slide, and I'm sure Paul will come back on it, is just to analyze the activity of the EEG. So if you have a decrease in fast alpha activity, an increase in slow delta activity, so reduced brain function, you can have a decrease and calculate a decrease in alpha delta ratio. And this is an example of a patient with delayed cerebral ischemia where this decrease in alpha delta ratio preceded the occurrence of the symptoms. So by using the EEG and combining EEG with other tools, you can assess and manage delayed cerebral ischemia, and this has been incorporated in the recent guidelines, the consensus guidelines in the neurocritical care on SAH, and there are even recent data showing that decrease in faster EEG activity help targeting CPP in severe, so comatose stroke patients, in which neurological exam is not always reliable. And in terms of prognosis, another important issue is that we tend to see EEG as a way, just as a snapshot. And so you see seizures or not. You see theta activity, you see epileptiform patterns. But actually EEG, we went recently into a more dynamic approach where you see the response of the activity after, for example, a painful stimulation, or you see trends of activity over time. And so this dynamic analysis is, again, I'm stressing this point, I think is very a new way of using EEG, and I think that for the prognostic assessment, particularly in patients with coma after cardiac arrest and hypothermia, is interesting. And this is a very nice study from Italy, published recently in Critical Care, where they used the dynamic monitors of brain function, coupling EEG continuous monitoring and evoked potentials. And they use, and I really recommend this paper because really is an approach I like. I would like to know about the implementation of the system, but I think it's an interesting way to go. And this is an example of EEG and evoked potentials worsening in a patient. And they collected and used this approach into a group of patients, and you see that the EEG decline from first to third observation, so a worsening, was really a significant association there in terms of worse outcome. And worse outcome meant also, for example, ICP elevation. So you can track secondary brain damage. And to conclude, because of the time running, and just to summarize briefly, we used and others used this approach, and we actually checked changes in the EEG reactivity. So we go for a standardized painful stimulation, and you see whether the EEG reacts or not. And we assessed this prospectively into 111 comatose cardiac arrest patients treated with hypothermia. And when you incorporate the EEG reactivity into a multimodal approach where you have neurological examination, so this answers Yannick a question. You have to incorporate neuroexamination, then EEG, and then evoked potentials. We were able to really increase our predictivity of good outcome. This was intermittent EEG at the end of rewarming, and this was continuous EEG during hypothermia. And actually what is very important I think in this study is that we increase the prediction. So you increase your prediction that the patient will awake and recover. And this is more powerful than the evoked potentials. Evoked potentials are good when they're absent. I mean, good because the patient, it's 100% predictive of death. But it's not that good in the 40% of patients where there is something. And if you use EEG reactivity, you go from 65% to 85% of prediction of good recovery. And I think that with these I end with a take-home message. Hopefully I answered the question about intermittent EEG are insensitive to detect non-convulsive seizures. So you need to go for continuous EEG. The exact duration is controversial. And half of the patient, and even more, you get seizures in the first hours of continuous monitoring. I think that if we go for EEG and if we talk about dynamic brain function, simplified montage have these advantages. And so I think we should go for at least 9 to 14 electrodes of even more. And finally, intermittent is useful in unexplained coma, and continuous EEG, I think, is a promising neuromonitoring tool, as I shown for brain dysfunction and prediction of prognosis. Thank you.
Thank you, Mauro.